Welcome to MedBlog, and today we are going to talk about hypertension. To talk about hypertension, we must know what blood pressure is. Blood pressure refers to the pressure, the force exerted by the blood on the blood vessels, notably the artery. It is given by the formula cardiac output times systemic vascular resistance. The cardiac output is the product of heart rate and stroke volume. Systemic vascular resistance has a number of determinants. The narrower or smaller the lumen of the blood vessel is, the higher the systemic vascular resistance. The longer the blood vessel, the higher the systemic vascular resistance. And the more viscous the blood, the higher the systemic vascular resistance, which should make enough sense. The British Hypertension Society brings to us a classification of blood pressures. Optimal blood pressure being a systolic of less than 120 mm of mercury and diastolic of less than 80 mm of mercury. Normal BP of less than 130 systolic and less than 85 diastolic. High normal BP of 130 to 139 systolic and 85 to 89 diastolic. Grade 1 hypertension being 140 to 159 systolic and 90 to 99 diastolic. Grade 2 hypertension being 160 to 179 systolic and 100 to 109 diastolic, and grade 3 being greater than 180 systolic and greater than 110 diastolic. Always given as systolic and diastolic in millimeters of mercury. Hypertension can either be primary or secondary. Primary or essential hypertension are not secondary to any underlying disease but are associated with a number of risk factors, which include the age. The higher the age, the higher the incidence, and greater at above 60. There is a male predominance. Obesity is a risk factor. Sedentary lifestyle, smoking, cigarettes, alcohol, a positive family history of essential hypertension, diabetes mellitus, excess salt intake, and being African are risk factors. Secondary hypertension is hypertension that is caused by an underlying disease. For example, pregnancy. In pregnancy, the hypertension here is called eclampsia or preeclampsia, and it occurs at 20 weeks of gestation or beyond that period. Hypertension can be caused by some medications such as non-steroidal anti-inflammatory drugs like ibuprofen, antidepressants which potentiate the release or effect of epinephrine or norepinephrine. Aortic coarctation is a known cause of hypertension. Some renal diseases are known causes of hypertension. For example, glomerulonephritis, renal vascular diseases like renal artery stenosis, polycystic kidney disease. Endocrine diseases are among the important causes, such as pheochromocytoma, in which there is increased adrenaline, Cushing's syndrome, in which is increased cortisol, which upregulates alpha-1 receptors on arterioles and increases the sensitivity to adrenaline. There's also Crohn's disease, in which there is increase in aldosterone, which increases sodium reabsorption, and water follows, for which there will finally be increased blood volume and blood pressure. Hyperparathyroidism is associated with increase in calcium, which increases muscle tone and increases vascular resistance. It also stimulates aldosterone release. Thyrotoxicosis increases cardiac output and heart rate by upregulating beta-2 adrenergic receptors. Hypothyroidism paradoxically also does that by increasing diastolic blood pressure, causing decreased elasticity of the arteries, and causes hypercholesterolemia, and it occurs in 3% of hypertensive patients. Acromegaly, in which there is increase in the growth hormone, causes hyperinsulinemia, which decreases blood potassium, which later on stimulates kidney reabsorption of sodium and water. Congenital adrenal hyperplasia is another important cause. Liddle syndrome and 11-beta hydroxysteroid dehydrogenase deficiency are other important causes of hypertension. When making the diagnosis of hypertension, we must consider the clinical features, most especially BP measurements, which is used to confirm the diagnosis. We need to take two BP measurements at least 6 hours apart. Consider taking a supine and sitting position and in both arms. Aortic coarctation presents on physical examination with radiofemoral delay. An enlarged kidney will be ballotable on physical exam, and it points towards diseases such as polycystic kidney disease. Renal artery stenosis presents on physical examination as an abdominal bruit when auscultating. The characteristic features of Cushing syndrome should guide us towards a diagnosis also, such as a buffalo hump, purple striae, central obesity, moon face. Also, consider risk factors such as obesity, ethnicity, which can be seen on physical exam. Also, signs of complications are important to note, such as in stroke, we can see facial deviation. Heart failure, we can have crackles, myocardial infarction, hypertensive retinopathy, which will see the characteristic changes on fundoscopy. The investigations to be done in a suspicion of hypertension include to confirm the diagnosis. As already mentioned, we need to do serial blood pressure measurements using a sphygmomanometer. Also, we should identify risk factors like diabetes, for which we must do a serum glucose, either fasting blood sugar, random blood sugar, or a glycated hemoglobin. We need a lipid profile also to know the amount of LDL and HDL cholesterol. We should also identify secondary causes, such as in urinalysis, the amount of blood and proteins tells us the syndrome involved, which can guide us to whether it's a glomerulonephritis. Blood urea creatinine helps us diagnose a chronic kidney disease, which can be a cause or a consequence of hypertension. Thyroid function test is important to diagnose a thyrotoxicosis or hypothyroidism. Renal ultrasound helps us diagnose a polycystic kidney disease. Renal angiography is important to diagnose a renal artery stenosis. Urinary catecholamines help us diagnose pheochromocytoma. Urine cortisol or DEXA suppression test in diagnosing a Cushing's disease. Also, plasma aldosterone helps us diagnose a Crohn's disease. Fourthly, we should identify complications, and this should be done when there are visible signs or symptoms such as fundoscopy to identify retinopathy, cardiac echo, chest x-ray and ECG to identify heart complications, and cerebral CT scan for a stroke. For the treatment of hypertension, we can use antihypertensive medications such as diuretics, which increase urine secretion and decrease plasma and extracellular fluid volumes. By so doing, they decrease the preload, the cardiac output, and systemic vascular resistance. Examples are thiazide diuretics, which act on the early part of the distal convoluted tubules to inhibit sodium and chloride co-transport, hence increase sodium chloride excretion. Important side effects are hypokalemia, hyperglycemia. Examples are chlorothiazide, hydrochlorothiazide. Potassium-sparing diuretics such as spironolactone act on the collecting duct and distal convoluted tubule to competitively inhibit or antagonize the function or action of aldosterone. Another class of diuretics are loop diuretics, which act on the thick ascending limb of the loop of Henle to block sodium, potassium, and chloride co-transport. Examples are furosemide and bumetanide. Also, angiotensin converting enzyme inhibitors, also known as ACE inhibitors, they block angiotensin converting enzyme, which is the enzyme that converts angiotensin 1 to angiotensin 2, and stopping the RAS pathway. Examples of such medications include captopril, ramipril. Angiotensin receptor blockers function by blocking the action of angiotensin 2 by binding to its receptors on smooth muscles. Examples include losartan and valsartan. There are also calcium channel blockers, which act by blocking L-type channels, hence they prevent the binding of calcium to its receptors and preventing smooth muscle contraction. Examples of such medication are nifedipine, nicardipine, and amlodipine. Another very important class of antihypertensives is centrally acting antihypertensives, which decrease sympathetic outflow by stimulating central presynaptic alpha-2 adrenergic receptors in the medulla to inhibit norepinephrine release. Example, methyldopa. Another important class of antihypertensives is beta-adrenergic receptor blockers, which block beta-adrenergic receptors for adrenaline. Some block only beta receptors, which are found on the heart, smooth muscles, and kidneys. Examples are atenolol, metoprolol, bisoprolol. Some block both beta-1 and beta-2. Beta-2 are found on vascular smooth muscles and on presynaptic adrenergic neurons. Examples include propranolol. Some block both beta and alpha receptors. Alpha receptors are found on blood vessels. Examples are labetalol, carvedilol. Adrenergic receptor blockers competitively and selectively block alpha-1 adrenergic receptors, which are found on the smooth muscles of arteries, veins, and bladder sphincters. Examples include prazosin, terazosin. Non-pharmacological management include the cessation of cigarette smoking, decreasing alcohol intake, also decreasing salt intake. We also need to decrease the amount of saturated fatty acid food intake, such as cheese, butter. Correct obesity for those who are obese need to lose weight, regular physical exercises, and increase consumption of fruits and veggies.